All right, good afternoon, everyone. We are going to start our mini oral session 1. Just a couple of reminders. Some of these mini oral presentations are actually going to be on the on-demand section of your meeting app. So please check those out. There are videos on there, easy to view anytime, and they will be up for the next 3 months. And secondly, even though these are mini oral sessions or presentations, we do have time for questions. But please try to think about the questions quickly, get to the microphone, and we'll get your questions asked. All right, to start us off, we do have a little bit of a reschedule. Dr. Tilva will be starting us off this session with actually number 17, returning to clinical years, post-research needs assessment of surgical residents.
Good evening. My name is Keval Tilva from the University of Colorado, and I'll be presenting 2 surgical educations talks, first starting with this talk about residents who return to clinical training after taking dedicated time to perform research. So the aim of this study was to perform a needs assessment and understand the perceptions of faculty and residents when they return to clinical training after taking time to perform research. We sent a voluntary anonymous survey to those faculty and residents. We had a 24% faculty response and about a 68% resident response. These were residents who did research and then went back to clinical training. So we asked them to compare these 2 groups, residents who had an interruption in their training to residents who went straight through and didn't have an interruption. And we asked them to evaluate them in 3 different areas: technical skills, general knowledge, and clinical aptitude. And there were 15 different domains taken from the ACA-GME core competencies. And we asked them to evaluate them with a Likert scale, below level of clinical peers, same as their peers, or above level of clinical peers. And as we had hypothesized, the main areas where attendings felt that residents needed improvement were all technical areas. So tissue handling, dissection, laparoscopic skills, intraoperative decision-making, and knowledge of operative flow. So over 50% of faculty thought residents were deficient in these areas. However, there was agreement with residents, however, to a lesser extent. So fewer residents felt that they need improvement in these areas, but they agreed that these were the areas where they were most lacking. So overall, we saw that there is some kind of feedback going on between residents when they come back to operate after taking dedicated time to do research. They understand that they are behind in these technical skills, but right now, we don't have any kind of standardized curriculum for residents when they come back from the lab. So we use this information to design a new curriculum, which is highlighted here. It involved a workshop, a dry lab, porcine wet lab, as well as some operative case decisions to go over decision making. And so we're in the process of evaluating if this new curriculum has made any improvements to resident education.
Thank you.
A question?
So Dan Dent, San Antonio. We did something very similar, but interestingly, what we found when we looked at the July evaluations of our residents returning from the lab is that the residents returning from the lab scored higher and better on technical skills and clinical performance than the residents who did not do any lab time. And the number one predictor of how you're going to do in July of your PG3 year is how you did as a PG2, whether you go in the lab or not. And so I would suggest you look at it and you're doing great work, but this may just be a PGY3 prep curriculum that you need all your PGY2s to do at the end of the year, or your research residents right before their July PGY3 rotation.
I see. Yeah, I mean, skill atrophy has been documented, and this was really a survey looking at the perceptions of both the faculty and the trainees, and not necessarily their official clinical evaluations. But it would be interesting if we were able to track somebody's performance as a second year and then how that impacted their performance as a third year, even if there was a gap.
Great presentation, Alexis from Denver, Colorado. Were you able to look at the clinical duties that the different research residents had, such as the number of moonlighting sessions they had, and to take that into calculation?
Yeah, so at our program, residents do routinely perform moonlighting in ICUs, but there is no official operative time for research residents. Some people do like organ procurements if there's a need for that for transplant, but there's a very limited amount of operative experience during that time. So it's mainly ICU care, and residents rated themselves as actually being better than peers who did not take time off when it came to management of complex patients and post-operative things, probably due to that extra ICU experience.
Dr. Moore?
I don't want to make this a Denver thing, but I'm just curious if you looked at what the research experience is and how that impacted their clinical performance. So for example, Alexis now is a T32 resident, and she just finished 20 pigs and put in 40 Reboas and watched pig go in shock and resuscitated them. But surely that's different than some other resident who's sitting down a microscope looking at the P47 and the membrane of a neutrophil.
Definitely, point well taken. That's definitely a big part that also impacts the confidence of residents, as we had in our session when we had a pig lab, residents who had been doing animal research and worked on their technical skills during that research time definitely felt more comfortable than the residents who hadn't been doing that. And so we felt like this curriculum was there to help kind of normalize that experience, although 1 or 2 sessions can't make up for a repeated experience in the lab.
All right, Dr. Tilva, if you want to move on to your next presentation, education resource use by surgical residents pre and post-COVID, and the winner is Netflix.
That was just to get everyone's attention. So we sent out a survey basically looking to see if the disruption of the pandemic that caused all didactics to become virtual sessions, if that changed how residents were using their time to study, and if they felt like that change to a virtual format improved how they were studying and preparing for their clinical duties. So we sent out a survey to residents. We had about a 52% response rate, and we basically asked them, what are you using to study? How often are you studying? What's your preference? Which resources do you use the most? How much do you spend studying, and what are the goals of your studying? So overall, 94% of residents were using textbooks, and then a lot of people were using TrueLearn, podcasts, online videos. Our program provides SCORE, but only about half of people were using SCORE. And to many attendings' dismay, only 50% of residents were using journal articles to study. And then the weekly didactic that we had before our grand rounds that was in person and then got switched to a virtual format, only 13% of residents were using those slides to study from. This table here is a little bit busy, but basically it's saying that it didn't really matter if it was before or after the pandemic. It didn't make a difference what resources people were using, but what was significant was whether or not was depending on the goals of somebody's studying time. So if they were using a resource to prepare for the AB site versus for the OR, it made a big difference what they were using. We also asked them how much time they spent studying. It didn't really make a difference whether it was pre or post pandemic. People spent the same amount of time, whether their free time changed or not. And then we asked them whether they felt that changing the didactic from in-person to a virtual format improved their learning experience. And it was pretty much a bell-shaped curve. There was a couple people, 10% roughly, that either strongly agreed or disagreed. And then most people either, weakly agreed, disagreed, or most were neutral. And so that's still a point of contention as we figure out, how we're gonna, if we're gonna go back to a in-person learning environment or continue it as a virtual thing, because some people hate it, some people love it, and it's pretty split. And so overall, the pandemic didn't really change how people were studying or how much they were studying. And the biggest thing is, if people are studying for the OR or for the AB site exam, that's what determines what people are going to use. And the next steps are we're going to evaluate, what faculty would expect residents to use to prepare and see if that is congruent with what residents are doing.
Dr. Tilva, I think that's great. Ryan Lawless from Denver. Question, Did you look at the different years of the residents? So are interns using more textbooks to prepare for the ABSITE and chiefs using more literature to go to the operating room? Is there a breakdown the difference between the year?
Yeah, we did ask the demographics of what PGY level people were. However, we didn't, it was kind of scattered in terms of results. There wasn't enough statistical significance to say whether or not it was a true trend or just something that was in the data. So we'd have to expand the sample size to determine that.
Great, thank you.
All right, thank you.
So our next presentation is by Dr. Lawless from Denver Health Medical Center. A cup a day keeps the stress away, surgeon caffeine consumption and heart rate variability.
Good afternoon. I have no disclosures. So caffeine is the most common and ubiquitously available performance enhancing drug worldwide. It's available 24/7, 365 in all shapes and sizes and forms. We use it often to combat fatigue, to improve our alertness, and often to try to improve our reaction time. Heart rate variability. This is something that's been in the literature recently as far as talking about surgeons, but it's what is defined as the time between beats. And it's a measure of stress and recovery. However, it's individualized per person, and typically a higher heart rate variability indicates that you are recovered or ready to take on some stress. We've previously shown that high and moderate stress rates do occur and are evidenced by a lower heart rate variability in surgeons specifically that take in-house call. And generally, it takes about 3 days for those heart rate variabilities to return back to their baseline. So this kind of brought about the mixture of the two, as does caffeine in fact impact our recovery of measurements after in-house call. And so we hypothesized that caffeine consumption during in-house call will increase the heart rate variability percentage compared to no consumption of caffeine. We performed a post hoc analysis of prospective collected data from 2 level 1 trauma centers and used continuous physiologic measurements from the Whoop device looking at heart rate variability. We did a linear mixed model and we're reporting in least mean squared. There were 17 surgeons in the original data set. 13 said they either did or did not take caffeine, with 7 of them saying that they did consume caffeine. So if you look at figure 1, what that shows is that surgeons that did consume caffeine do have a higher rate of their heart rate variability percentage closer to normal, meaning they look like they're recovered. So we broke this down even further to take out those ones that drink a lot of caffeine, like many of us. And so if a surgeon drank 2 or more cups of caffeine, consume caffeine 2 or more days, including their call and post-call, they actually look like they recovered much, much faster. So what we concluded was that caffeine consumption during and following in-house call is associated with a significant persistent increase in their heart rate variability percentage following the call. But we need to look at this more. Is this actually, we're better surgeons, or are we just masking our fatigue? Thank you.
I've got a question. I've been told that alcohol consumption can also affect heart rate variability and recovery. Was that controlled for in the study?
So that was not controlled for in this particular study. It was more difficult to control as we did not ask this question in this data set. Hopefully future data sets that may or may not have been collected by someone that's on this panel will elucidate that later. But I wore the device myself and alcohol crushes my heart rate variability.
It's coming.
Did you consider doing a subjective assessment of the surgeons about their subjective feeling of fatigue or tiredness in any of this process? I'm just curious what their subjective responses were compared to the heart rate variability.
Yep, to be continued. Same data set, hopefully come out soon. A lot more data as well. And so I won't give anything away, but I know I feel like crap after, even though I've drank 4 or 5 cups of coffee. Thank you.
Thank you. Up next, Dr. Terranella, acute skin toxicity following radiation therapy and trastuzumab, amantacine use.
All right. Hello, everyone. I'm Samantha Terranella. I'm a surgery resident at Rush University. Thank you for allowing me to present here. So, no disclosures. So trastuzumab emtansine, or TDM1, is an antibody chemotherapy drug conjugate that was approved for use in 2019 for patients with HER2 positive early breast cancer who are found to have residual invasive disease at the time of surgery if they completed neoadjuvant chemotherapy and hormone therapy. The clinical trials for TDM1 demonstrated improved invasive disease-free survival compared to trastuzumab therapy alone. As approval for TDM1 is fairly recent, we present 2 cases of severe radiation-induced skin changes in patients following TDM1 therapy alongside radiation therapy of their breast. Both patients were in their 6th decade of life. They both had invasive ductal carcinoma. They both underwent neoadjuvant therapy, and the patient on the right of the screen, or your left, she underwent lumpectomy with sentinel lymph node biopsy. The patient on the left underwent modified radical mastectomy with axillary lymph node dissection and had tissue expander placement. Postoperatively, both patients were switched to TDM1 therapy because they were both found to have residual invasive disease in the specimen. Both underwent adjuvant radiation, and the patient on the left of the screen, she developed severe erythema, pain, edema, and eventually fibrosis of the breast. She elected to undergo completion mastectomy with deep flap reconstruction. You can see she had an excellent result after that. The patient on the other side of the screen, she also developed pretty severe skin necrosis and eventual dehiscence of the wound. She underwent debridement, removal of her tissue expander, and advancement flaps, which was her choice. And she had an okay result. It's not as cosmetically pleasing, of course. So the reason I bring this up, treatment of breast cancer can result in skin toxicity in up to 85–90% of patients with breast cancer. There's a lot of risk factors for acute skin toxicity with radiation, some of them being elevated BMI, previous augmentation, conventional radiation therapy, and chemotherapy use, and more recently we're seeing with hormonal therapy. So prevention and treatment options of this can be proper skin hygiene, topical steroids, wound care management with hydrogels or hydrocolloids, and then sometimes you have to do debridement and flap advancement. As newer treatments become available for advanced breast cancer, such as TDM1, I think it's important to discuss real-time side effects that we're seeing in practice so we can identify patients early on for preventative measures and treatment approaches strategies for these complications. Thank you.
So the results of your study, does that change like what you would recommend in terms of patients that get treated with this, and maybe
Yeah.
whether you would do radiation, or if so, what type of modality you'd use?
I think, so if you identify a patient that has had augmentation or elevated BMI, you can consider doing something like hypofractionated radiation. These patients both got conventional dosing radiation, which is associated with higher risk of skin toxicity. So you can push for that. It really wasn't out at the time they were getting treatment, was undergoing clinical trials at that time. So that's one thing. Second thing is you can institute preventative measures, good skin hygiene, avoidance of deodorants, fragrances, things like that. And I don't think that's always pushed on patients.
What about smoking?
Smoking is actually, there's not really good data to support smoking causing more skin toxicity with radiation, but in terms of healing flaps, deep flaps, things like that, they have worse outcomes if they're smokers. So, yeah.
Nice job.
Thank you.
Good job.
Thank you.
So the next paper that will be presented here live is by Dr. Andy Liu, or soon to be Dr. Andy Liu, from the surgery group at Los Angeles. It's Hartmann's reversal is more complex than elective left colectomy. And don't forget, you can see the other recorded episodes on the app for the paper 4.
Okay. Hi, everyone. My name's Andy Liu. I'm a recent Lee graduated UCLA undergraduate student, and I'm a clinical research assistant working with Dr. Yosef Nasseri at the surgery group of Los Angeles, based at Cedars-Sinai Medical Center. I would like to thank the Congress for the honor of presenting today. Today, I'll be presenting our study, Hartmann's reversal is more complex than elective left colectomy. We have no disclosures. Hartmann's reversal, or restoration of intestinal continuity by closure of the end colostomy following Hartmann's procedure, is associated with significant technical difficulty and morbidity. The literature on this operation is scarce, and past studies have reported morbidity and mortality rates of up to 50% and 7% respectively. We sought to evaluate the complexity and outcome of Hartmann's reversal. We chose to compare Hartmann's reversal to left colectomy for cancer and diverticulitis because they are both elective operations with similar resultant left-sided colonic anastomosis. We performed a retrospective review of a prospective database consisting of 27 Hartmann's reversal patients and 87 left colectomy patients operated on by 4 surgeons at our center over the span of 7 years. In our study, we compared preoperative risk factors, intraoperative events, and short-term postoperative outcomes. Here's what we found. So in the Hartmann's reversal arm, we observed patients with a greater comorbidity burden, as indicated by the higher percentage of ASA grades 3 and 4, and higher Charlson comorbidity index scores. Patients coming in for Hartmann's reversal are much sicker to begin with. Furthermore, in terms of surgical technique, we found that Hartmann's reversal cases were more likely to be performed in an open manner than in a minimally invasive fashion. Furthermore, the rate of conversion to open surgery was higher in the Hartmann's reversal group than the left colectomy group. We also found that the Hartmann's reversal operation on average was 50 minutes longer with a higher number of intraoperative complications. Although we did not find any significant differences in the number of postoperative complications per patient, we did note that the length of hospital stay and the percentage of 30-day readmissions trended higher in the Hartmann's reversal group than the left colectomy group. Lastly, the Hartmann's reversal group took nearly 1 day longer for bowel function to return. In conclusion, Hartmann's reversal is a more complex surgical operation when compared with elective left colectomy. One should consider alternatives to Hartmann procedure at the index operation, such as primary resection and anastomosis with a diverting loop ileostomy. We also recommend best optimizing patients prior to Hartmann's reversal for favorable surgical outcomes. Thank you very much.
Good job. One question for you. Did you have any information on the patients who underwent the Hartmann's reversal? How much time was between their initial operation and the Hartmann's reversal? And then secondly, do you have any information about whether the splenic flexure was actually taken down at the index operation and if that made an impact on the difficulty?
The data on the time, the interval between initial Hartmann's procedure and reversal in our study was 11.25 months. And in terms of the splenic flexure data, we did not collect that data, and maybe in the future we will look into that.
Okay. All right. Thank you very much.
Thank you so much.
Up next, from the University of Colorado, Dr. Yoeli, the Pediatric Liver Transplant Donor Risk Index.
Hi, my name is Dor Yoeli. I'm a general surgery resident at the University of Colorado. Thank you for this opportunity to share our research. The Donor Risk Index was introduced in 2006 as a score that quantifies the risk associated with liver grafts based on its donor's characteristics. However, this score was derived entirely from adult donor data and did not include the competing option of living donation. Therefore, its application to pediatric liver transplantation is limited. A similar score that is specific to pediatrics could improve both waiting list and post-transplant outcomes by optimizing donor selection. The aim of our study was to derive such a score, which we termed the Pediatric Liver Transplant Donor Risk Index. To do this, we reviewed the National Transplant Database from 2002 through 2020 and performed a multivariable Cox regression for graft loss. Our results showed that 5 donor characteristics were associated with graft survival. Those included living donation, donor age, cause of death for the deceased donors, donor race, and smoking history. We used these results to derive a formula to calculate the Pediatric Liver Transplant Donor Risk Index. And when we stratify recipients by their donor's risk index score, we see the ones with the highest score and therefore the highest risk had the worst survival, and those with the lowest score and the lowest risk had the greatest survival. So in conclusion, the pediatric liver transplant donor risk index score is a novel risk stratification method that is composed of 5 donor characteristics that are available at time of organ offer. Transplant surgeons can use this score to objectively compare organ offers and consider alternative options, including living donation. Thank you.
So I think haven't studies shown that if your donor risk index is high, that you tend to actually, those livers get used for kind of lower acuity recipients? So did you control for that?
We did. We also included in the multivariable model a host of recipient factors to help factor those in. It is a tough choice though, because those with the lower acuity can perhaps wait longer, except for like cancer cases where you do want to do it quicker and they do have lower scores. But it is a complex decision making, and this is one additional tool to help with that.
Great.
Thanks.
So the next paper is going to be presented by Dr. Kristin Kohlberg from Swedish Medical Center in Colorado. The title is Rising Incidence of Appendiceal Adenocarcinoma in the United States.
It's actually Swedish Medical Center in Seattle. But,
Oh, sorry.
Yeah, I was born at the one in Colorado, but
Oh, perfect.
all right. So hi, my name is Kristen. I'm a general surgery resident at Swedish, and I'm presenting on the rising incidence of appendiceal adenocarcinoma in the United States. Left click. There you go. I have no disclosures. So appendiceal adenocarcinoma is a rare cancer, and because of this, incidence hasn't been well described. We sought to look at the incidence of appendiceal adenocarcinoma in comparison to colorectal adenocarcinoma. To do this, we used the National Cancer Institute Surveillance, Epidemiology, and End Results Program database. This contains observational de-identified population-based data for all cancers, including appendiceal and colorectal adenocarcinomas, and it captures greater than 99% of the US population from 2001 to 2017. It's also publicly available online. We found 28,859 cases of appendiceal adenocarcinoma and 1,844,082 cases of colorectal adenocarcinoma during this time period. The majority of cases for appendiceal adenocarcinoma were in female, non-Hispanic, white patients aged 55 to 69. Interestingly, 45% of appendiceal adenocarcinoma cancers presented with distant metastases. In addition, over the time period, the appendiceal adenocarcinoma had an annual percent change of positive 2.8% for a total increase in incidence of 47% over the time period, in contrast to other colorectal adenocarcinoma, which had a negative 2.9% annual percent change for a total decrease of 34% in incidence over the time period, which you can see there. So in conclusion, while appendiceal adenocarcinoma is rare, it's increasing in incidence and often presents with metastatic disease. And we think that this should be considered when you're looking at certain populations and advising patients on what to do, especially in the case of more medical management of appendicitis with Contextual, and also just greater awareness of appendiceal adenocarcinoma is probably needed when thinking of patients and risk groups with colonoscopy. Thank you.
I have just a real quick question, pardon my ignorance, but isn't there a movement towards non-operative management of appendicitis? And if that's the case, and you non-operatively manage someone presenting with appendicitis that has adenocarcinoma of the appendix, what's the natural history of those patients? And is there a role for CEA levels in treating patients that would potentially be in the highest risk group for adenocarcinoma of the appendix?
I think that's an excellent question. I don't actually have the answer for that, but I would suggest, at least in patients of an appropriate age group, like the 55 to 69-year-olds, that screening would be appropriate. However, you could also make the argument that the incidence is still very low. So it might be not very cost effective.
How much of the uptake in adenocarcinoma of the appendix do you think is attributed to just relabeling and agreement between the pathologists? Because I think when it comes to appendiceal neoplasm, there's so many of them, and there's so many of them do overlap: mucinous, not mucinous, low grade, etc. And I'm wondering if is some of it due to us getting the labeling right and the pathologists are not agreeing on the final path?
Yeah, I think that's an excellent question. I don't have a great way to evaluate this for appendiceal cancer in general, for neuroendocrine and stuff, which I'm not discussing here. Like the way we categorize malignancy has changed, like in 2010 and 2015. So that is an issue with this data set. However, nobody's really described this at all, but I agree that's something that we don't necessarily factor for. So it's an excellent point.
Thank you. Up next, Dr. Moore from University of Colorado with a presentation entitled, "Should Enhanced Recovery After Surgery Be Implemented in Laparoscopic Donor Nephrectomy for Living Kidney Donation?"
Thank you, Dr. Coleman and Southwest Surgical Association for the opportunity to present our group's work. No financial disclosures. So laparoscopic nephrectomy has become the standard of care for living donor operations with kidney transplant. And enhanced recovery after surgery has been utilized in different surgical specialties. So we hypothesized that there are different variables associated with ERAS that we would see in our donor population that could predict early recovery and leaving the hospital on postoperative day one. Our study included patients from 2017 to 2021. Our primary outcome of interest was leaving the hospital on postoperative day one. And we looked at these variables, preoperative, intraoperative, and postoperative that were associated with this outcome. We included 422 patients. The discharge rate of leaving postoperative day one was 28%. But if you look at a temporal trend, we can see an increase from less than 10% to over 60% over the past 5 years. We looked at variables associated with leaving early. One was using preoperative Lyrica. Another one was limiting intraoperative Versed. And finally, limiting fluids postoperatively, which had the highest odds ratio of 5.8. And importantly, we see that the safety between these variables of leaving post-op day one versus leaving later had no impact on your creatinine 1 year after your operation. So in summary, 5 years of laparoscopic living donor nephrectomy, we identified several modifiable variables that could get you out of the hospital early. These were using preoperative Lyrica, limiting intraoperative Versed, and limiting postoperative fluids. And these findings are very consistent with other ERAS protocols of using alternative medications to narcotics and minimizing fluids. Happy to answer any questions.
Good job. One question for you. In terms of limiting postoperative fluids, have you kind of worked out an education strategy for this, as it's often residents or APPs who are managing these patients immediately post-op and maybe worried about urine output? How are you getting that message to the people making those orders?
Yeah, that's an excellent question. And if you see Dr. Keneally laughing in the background, he had to actually educate his partners as well. The sort of feeling is that when urine output goes down, the reflex is to give people large boluses of IV fluids. And we introduced just a post-op order set where your maintenance fluids go to 75, and using that protocol and re-educating the residents and APPs that if urine output drops off, you should think why the urine output dropped down rather than reflexively bolusing has helped with that.
Wonderful.
There's probably no patient population that undergoes an operation that we know more about their renal function than these patients. So they're so healthy that we're taking out a kidney. So we're not really too concerned about their urine output. Because if we were, then we did something wrong.
Yes. Thank you.
Next paper will be presented by Dr. Laura Leonard, University of Colorado, titled "Unmeasured Contextual Effects Are the Major Drivers Associated with De-Implementation of Complete Lymph Node Dissection in Melanoma."
Good evening. Thank you for that introduction, Dr. Rayburn. We did use National Cancer Database data for this work. Since 2010, there have been rapid advances in systemic therapy for adjuvant and metastatic melanoma. During this time, the surgical management of melanoma has also evolved significantly, as we heard earlier today during the surgical practicum. Using data from the National Cancer Database, we selected for patients who had a confirmed diagnosis of invasive melanoma, who underwent upfront surgical resection and had at least one positive sentinel node. We then performed a multivariable mixed effects logistic regression with a random intercept to determine the effect of patient, tumor, and facility variables on the use of CLND. Next, we used a novel method, the reference effect measures, or REM, to compare the contribution of contextual effects or unknown facility variables to the variation in CLND use to that of measured variables. On the left, you can see a stacked bar plot demonstrating that the percent of institutions always doing CLND decreased significantly, and the percent of institutions never doing CLND increased over time. On the right is a forest plot just of the patient factors we analyzed, but overall the factors including patient age, primary pair, tumor location, and mitotic rate were associated with undergoing CLND. We then used the REM to evaluate the effect of measured variables versus unmeasured factors on the de-implementation of CLND in patients with melanoma. In this REM figure, the wider the width of the bar, which represents the 90% REM range, the greater the contribution of that factor to the variability observed in the outcome, or CLND. So this figure suggests that contextual effects or unmeasured facility variables are the major driver of variation in CLND use in melanoma. This finding suggests that there's a lot of variability present in the surgical management of melanoma, which represents an opportunity for future work to decrease the variability and reduce the number of low-value procedures performed moving forward. I'd like to thank my collaborators, the University of Colorado, and my mentor, Anna Gleisner, who could not be here today. We'll take any questions.
So I listen to Behind the Knife when I run the stairs on call, and that's where I get all of my melanoma information from. But wasn't there a study that showed that there was no benefit to completion lymphadenectomy after this for most patients?
Yes, so the literature came for breast first in 2011 with the Z11 trial, and then followed with two studies in melanoma, the MLST2 trial and the DCOG trial. One was in America and one was in Europe. But yes, they showed no melanoma-specific survival benefit for CLND use in this subpopulation.
So was that, did you notice that there was a big decline when the results of that study came out?
So interestingly, in this data set, the trials came out in 2016. Even in 2012, 30% of institutions were not doing CLND for melanoma. That's pretty different from the breast literature, which shows that even after 10 years, 30% are still doing it. So it was definitely de-implemented at a faster rate than CLND for breast, but still not to zero. And so we may be over-treating certain populations.
Thank
Nice
you.
job.
Thank you.
Next up, Dr. William Brandon from University of Colorado, utility of using only left-sided adrenal vein sampling data in lateralizing primary aldosteronism.
Hello, my name is Will Brandon. I'm from the University of Colorado, fourth-year medical student, and I'll be presenting our team's work on the utility of using only left-sided adrenal vein sampling data in lateralizing primary aldosteronism. I have no disclosures. Unilateral primary aldosteronism is best treated surgically. However, imaging alone cannot distinguish laterality. Adrenal vein sampling is required for most patients, but is technically challenging due to anatomic variations of the right adrenal vein. Success rates are less than 50% in some centers. AVS compares the aldosterone and cortisol levels of the IVC and adrenal veins to determine the selectivity and lateralization indexes. When right-sided data is unavailable, we hypothesize that analysis of left side and IVC data can predict laterality. When left side levels are greater than 5.5 times the IVC levels, this indicates left-sided disease. And when left side levels are less than 50% of IVC levels, this indicates suppression, predicting right-sided disease. Our results have shown for the upper cutoff, when the left side levels are greater than 5.5 times the IVC levels, the positive predictive value is 100% for correctly predicting lateralization. But as you can see by these green dots, only 3 out of 21 patients met this cutoff. For the lower cutoff, when the left side levels are less than 50% of IVC levels, the specificity was only 90%, and 4 out of 19 patients with bilateral disease were incorrectly identified as having right side unilateral disease, indicated by these red dots. So in conclusion, the LAV-IVC 5.5, 0.5 criteria correctly predicts laterality in 54% of patients with unilateral disease, but incorrectly predicts the unilateral disease, leading to unnecessary surgery in 21% of patients with bilateral disease. Lowering the LAV-IVC cutoff to 0.1 or less than 10% of IVC levels would give a positive predictive value of 100% for both the upper and lower cutoffs. This would allow 22% of patients to avoid repeat AVS. Thank you.
Well, that's a very complicated thing to try and explain in 2 minutes, and I can say that I helped him put that together. And nice job, Will. But it's just a complicated thing to try and explain in 2 slides in 2 minutes. But nice work.
Good job.
Thank you.
So the next paper will be presented by Kishani Hathatumwagamo. I'm sorry, I know I butchered that, from University of California, Irvine Medical Center. It's entitled Mild and Severe Blood Alcohol Concentration Effects on Overall Trauma and Traumatic Brain Injury Outcomes.
Thank you. Hi, thank you for having me. My name is Kishani Hathatumwagama. I will be presenting on behalf of UC Irvine. I hope to attend med school in 2023. We have no disclosures. Nearly 40% of trauma patients present with positive blood alcohol levels. There have been mixed findings regarding the risk of mortality and thrombosis in trauma patients presenting with positive alcohol levels, particularly with traumatic brain injury or TBI. Our study utilized a large national database to understand the relationship between serum alcohol positive patients and trauma outcomes, with a focus on mortality and venous thromboembolism, or VTE. It also examined a subset of TBI patients, hypothesizing higher BAC to be associated with increased mortality. To accomplish this, the Trauma Quality Improvement Program was queried for adult trauma patients who were screened for BAC on admission. Patients with positive BAC were split into a mild BAC, less than 80 milligram per deciliter, and severe BAC, 80 milligrams per deciliter or greater, compared to a no BAC group. These 3 groups were compared using one-way ANOVA. Multivariable logistic regression models were used for separate analysis of VTE and mortality for both mild and severe BAC, controlling for known predictors of these outcomes, including age, sex, comorbidities, and vital signs. A planned subset analysis for TBI was also performed. All 3 groups had a similar median ISS score of 9. However, the rate of mortality, 4.5%, and of VTE, 1.1%, were higher in the no BAC group. On multivariable analysis, when compared to patients with no BAC, trauma patients with mild BAC had a lower associated risk of VTE. This persisted in the subset of TBI patients, and the risk of mortality was similar across all populations. When comparing patients with severe BAC to patients with no BAC, there was still a lower associated risk of VTE. However, all patients, including the TBI subset with severe BAC, had a lower associated risk of mortality. These findings suggest alcohol to be protective across all levels for VTE. However, only severe intoxication places the trauma patient at a decreased associated risk of mortality, which merits further investigation. Thank you.
I've always been convinced that it is protective, but maybe not. So just on call last night or a couple nights ago, I mean, there were like 2 patients that just were in the worst car accidents ever with very high BALs, and they just literally had no injuries. But your study seems to show that severe blood alcohol levels actually have higher mortality.
It actually, the higher your higher, yeah, VTE, but I think my study was showing that the patient population with a higher BAC is correlated to a decreased risk of mortality and of VTE. But there are mixed findings in clinical literature.
Great.
Thank you. Good job. Our last paper of the session is from Dr. Leonard again from University of Colorado. First start operative delays in breast surgery. What are the contributing factors?
Thank you. I'll be presenting on behalf of Tori Quinn, who couldn't be here today. And we have no disclosures. So for this study, we performed a retrospective chart review. We retrospectively reviewed all breast and oncoplastic procedures performed between January 2018 and December 2019 at a single academic institution. Of these, we specifically evaluated first start cases as cases that begin the operative delay are ideally primed for an on-time start. Documented delay types reported by operating room staff were drawn from the electronic health record, and scheduled operative times and actual patient arrival times to the operating room were also collected. The minutes between scheduled start time and actual in-room time were calculated, and then descriptive statistics were used to summarize these data. A total of 734 procedures were performed during the study period, 303 of which were first start cases. Of these, 57% of patients arrived to the operating room on time or early, and 43% arrived a median of 10 minutes late. Among these cases, delays were attributed to surgical team factors 51% of the time, which included delayed consent, delayed site marking, or updated history and physical. Patient factors 12% of the time, such as late arrivals or extended questions. Anesthesia factors 10% of the time, such as delayed local regional blocks. And equipment issues 9% of the time, such as delayed setup or lack of instrument availability. Table 1 demonstrates operative delays by procedure type. Overall, defining contributors to delays is critical in enhancing the efficiency of the operating room process. Further investigation into the specific components of each team's contribution will help to target interventions. Thank you.
So Dr. Leonard, if I'm interpreting this correctly, what you're saying is that it is in fact not anesthesia's fault.
So that's an interesting point. We've also done follow-up survey data where we ask providers of different provider types to document the delay, because the electronic medical record documentation is all from nursing, so it's a little subjective. And interestingly, there's no correlation between the delay when you ask different providers. So it's very much pointing fingers across the drape.
This is my shocked face. Dr. Lawless.
Dr. Lana, that's great to look at, and I appreciate the work. The question I have is, did you look at the day? So is Monday worse than Tuesday, worse than Friday?
That's a great question. We didn't for this study, but we're doing a follow-up study with a larger data set, and we should have the power to look at day of the week as well as other factors such as whether there were multiple operative teams involved, which is often the case with breast and plastics.
Anecdotally, it's interesting that the people that are documenting why things are delayed are never, ever the cause.
Yes, that's a point well made. The EMR also captures an anesthesia documented delay, but there is no box where the surgeon can fill in that there was a delay.
The other thing that you might want to look at is, I know that if I have the OR all day, like it's my room, I'm less concerned if I'm 10 minutes late with my first case, whereas if I have somebody following me, I'm more likely to be on time. So it's something else you could look at.
Absolutely. Thank you.
We look forward to the follow-up. Thank you. Thank you, everyone. This concludes the session, and please join us for the welcome reception to immediately follow. Thank you, everyone.
Try to